Good evening, doctors. So today we will be seeing one high yield topic which is often asked in INI-CET. Okay, ABG. ABG interpretation, how to make it as simple as possible. Okay, yeah, let's see this question. A 60-year-old male patient, a known case of type 2 diabetes, hypertension on irregular treatment, presented with unilateral leg swelling, severe leg pain, and high-grade fever for last 5 days. His BP now is only 70/50. Pulse rate 120 per minute. Temperature 100, dextrose 220. On examination, severe tenderness was present in the left leg. Skin over the swelling is erythematous. Peripheral pulses were palpable. Ultrasound venous Doppler revealed normal study. And they have given a mention of his kidney function test and ABGs, pH, PCO2 bicarb, and electrolytes they have given, and D dimer they have given, which has been found to be normal. Okay, normal D dimer with D dimer is normal, as well as in venous Doppler also revealed normal study. So that means DVT as a possibility is ruled out. A old patient with leg swelling, pain on walking, unilateral leg swelling, you should first think of DVT. They have ruled out DVT in your question. And also a diabetic patient on irregular treatment, he is developing unilateral leg swelling. DVT is ruled out. What more possibilities are there? The patient also had fever, high-grade fever for last 5 days, and tenderness on palpation. So all these point towards infectious cause here. Okay, that might be some cellulitis or some necrotizing fasciitis or some abscess. All these can be a differentials. Okay, but let's focus on our question. ABG interpretation in this patient is high anion gap metabolic acidosis with compensation due to decay. High anion gap metabolic acidosis with compensation due to sepsis. Without C option, high anion gap metabolic acidosis without compensation due to decay. High anion gap metabolic acidosis without compensation due to sepsis. So if you closely watch these options, they are told that this disorder is either due to decay or due to sepsis. From the options, we can know this thing. But if you closely watch on his dextrose, it's just 220. Okay, so diabetic ketoacidosis is more unlikely in this situation. Let's interpret the ABG. Okay, yeah. So I'll take you from the basics, how to interpret the basic ABG. Then we will step down one by one till we reach the advanced step. Okay, yeah. First, any ABG given to you, first step for you is to check the pH. pH should be your first step. Normal pH should be 7.35 to 7.45. Okay, if you want a single value, you can keep it as 7.4. Okay, normal PCO2, carbon dioxide partial pressure, should be 35 to 40. Okay, if you want a single value, take it as 40. And bicarb 22 to 26. If you want a single value, take it as 24. So 7.4 pH, 40 PCO2, 24 bicarb should be by heart in your mind. Okay, this you should never ever forget, because this is the basics from which we are going to step one by one. Next, okay, so this is the normal values we have remembered. First step in ABG interpretation is look at the pH. If pH is more, then it is towards alkalosis. pH is less than 7.45, 7.35, then it is acidosis. So first step in our ABG interpretation is checking for the pH. Okay, so see our question. pH is 7.20. So 7.20 is less than 7.35. So there is acidosis going on in our patient. Okay. Next step is to check for acidosis you have found out. Next is you need to check whether it's due to a metabolic cause or is it due to a respiratory cause. How to check? Check which is coinciding with the acidosis. If bicarb is reduced, then it is metabolic acidosis. If partial pressure of carbon dioxide is increased, partial pressure of carbon dioxide increases, carbon dioxide can't be washed out of the lungs, mostly due to some respiratory pathology. So, respiratory acidosis happens if partial pressure of carbon dioxide is more than 40. Carbon dioxide accumulates more. Then it is respiratory acidosis. PCO2 more than 40. Bicarb less than 24, metabolic acidosis. Okay. So coming to our patient, how is our patient? Bicarb is 16, PCO2 is 30. Okay. So what is coinciding here? Bicarb is 16, PCO2 is 30. Bicarb is less than 24. So our answer is metabolic acidosis. Nice. So next step we have bounced into. Third step, metabolic acidosis. Is this metabolic acidosis completely compensated or not? What is the mechanism of compensation? You should know this. See, any metabolic acidosis, which is a metabolic acidosis means it is a disorder of the kidneys. It will be compensated by the lungs. Okay, lungs will compensate by, how will the lungs compensate? In metabolic acidosis, acids are building up, so it will be compensated by the lungs puffing out the carbon dioxide. So carbon dioxide will decrease. Expected carbon dioxide will be 1.5 into bicarb plus 8 plus or minus 2. This is the expected by partial pressure of carbon dioxide. Okay, this formula you should memorize. So if you see here, partial pressure of carbon dioxide should be equal to R 1.5 into bicarb given here is 16 plus 8 plus or minus 2. So that will be 24 plus 8 plus or minus 2. So that will be 32 plus or minus 2. So it should be in the range of 30 to 34. If PCO2 is in the range of 30 to 34, then it is completely compensated. Only this disorder is going on. There is no other coexisting, another alkalosis, other acidosis, no. It is a single ABG disturbance. Okay, let's see. Our PCO2 was 30. That means it is falling within this criteria. Okay, so it is completely compensated. Completely compensated. Nice. So we have found out acidosis, which is a metabolic cause, and it is completely compensated. Okay. Next comes, if you diagnose a case of metabolic acidosis, next comes the question to calculate anion gap. Anion gap is crucial in case of metabolic acidosis. What is anion gap? Sodium minus measurable anions, chloride and bicarb. Okay, this is anion gap. So if you see here, what is our sodium and chloride? 135. So anion gap will be 135 minus of bicarb plus chloride. Chloride is 100. So 135 minus 116. Okay, so it will be 19. Just remember this thing. Anion gap more than 12. You should take it as high anion gap metabolic acidosis, also known as HAGMA. Okay, anion gap is more than 12 here. It is 19. So it is high anion gap metabolic acidosis with compensation that is due to sepsis or decay. What is the cause here? It is most probably a diabetic patient with unilateral leg swelling, tenderness on the severe tenderness on his leg, high grade fever, leg pain, all pointing towards some infectious cause, which might be some cellulitis or some necrotizing fasciitis or some abscess going on. The basic thing is some sort of infection is going on in this patient and his BP has drastically reduced, meaning that patient is developing sepsis and he is in septic shock. Okay, due to lot of endotoxins released into your blood, it will cause widespread vasodilation, and that is the starting point of septic shock. Okay, so this patient is having. So it is ABG. From the ABG, I can tell it is a high anion gap because anion gap is more than 12 in this patient. Then it is a metabolic acidosis because I found bicarb to be low and pH to be low. So it is metabolic acidosis and gap more than 12, and it is with compensation. Yes, with compensation only. I calculated the formula. Partial pressure of carbon dioxide is equal to 1.5 times the bicarb plus 8 plus or minus 2. Calculated there. 1.5 into 16 plus 8 plus or minus 2 I did. I got expected PCO2 in the range of 30 to 34, and this is in 30. Yes, I am on the right track. It is completely compensated. Yes. Is it due to decay or is it due to sepsis? Definitely it is due to sepsis because I have all criteria of sepsis fitting here. If you see closely in this question, the patient has fever, cellulitis, and if you see kidney function test, urea is also raised, creatinine is also raised. Okay, so this patient is also having acute kidney injury due to sepsis, and also if you see AST, ALT, all those liver enzymes is also raised. Transaminitis will tell. Okay, so that means liver is also getting inflamed. Sepsis affecting more than one or more target organs like kidney, liver, heart. Okay, causing hypotension. This we call it as multi-organ dysfunction syndrome, MODS. In short, we will tell multi-organ dysfunction syndrome, sepsis, septic shock. Septic foci has spread to the kidney and gone to the liver and also to the heart, causing hypotension, myocarditis. All those things are happening. The right answer is high anion gap metabolic acidosis with compensation due to sepsis. Okay, this is actually the first initial stages of ABG interpretation. We calculated the first pH, normal values we know. Then with pH value, we told whether it's acidosis alkalosis. Then we went into metabolic acidosis, how to calculate the compensations. And next, we saw from this itself, we found out the answer. Okay. Tomorrow, we will see some more interesting ABGs which need further evaluation. Like anion gap, if this high anion gap, then what more you should do. Okay. Delta ratio. See, these questions are more preferentially asked in INI-CET than NEET. In NEET, your level will end with interpretation of acidosis or alkalosis. Okay. Only in case of INI-CET, they will expect you, apart from calculating compensation, you should go more and you should calculate delta ratios and how to interpret delta ratios. If multiple ABG disturbances happen, how to interpret that. Those things are important in INI-CET. Okay. So today we will see these basics. Tomorrow we will go further more in this topic and we will learn some more advanced ABG interpretation. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.